So what if your skin's appearance is just completely lying to you?
Oh, I mean, it happens all the time.
Right. Like you look in the mirror, you see this calm, flat surface, and you naturally just assume everything is fine.
Exactly.
Yeah.
Because we are entirely wired to trust our eyes.
Yeah. But meanwhile, a massive immune invasion is secretly raging, like just millimeters below that peaceful exterior.
It's true. I mean, you scrape a knee, you see the blood, you watch a scab form, and you know it's healing. There's a real transparency to that.
It makes sense. It's cause and effect.
Right. But when you step into the world of inflammatory skin conditions, that dashboard just breaks down completely. The physical signs can be incredibly deceptive.
And that profound physical deception is exactly what we're unpacking in today's deep dive. We're exploring the microscopic battleground of the human skin.
Yeah, we're really zeroing in on this critical tipping point.
Right, that exact moment where a reversible active skin condition crosses the line into permanent irreversible damage.
And we are using a really complex condition called lichen sclerosus as our primary lens for this today.
Yeah, because it perfectly illustrates how active, destructive inflammation and then fixed, burned-out scarring can just seamlessly masquerade as each other.
They look identical on the surface sometimes.
It's wild.
Huh.
So to build this picture for you, we pulled together a massive stack of medical literature.
Really dense stuff, too.
Oh, yeah. We've got detailed histopathology notes, primary care dermatology guidelines, cutting-edge research on high-frequency ultrasound physics.
Even clinical commissioning policies.
Right, the actual rules that dictate how healthcare systems manage the aftermath of these diseases.
So whether you are currently dealing with an inflammatory condition yourself or, you just want X-ray vision into your body's largest organ, we've got you covered.
Our mission today is to help you spot the crucial difference between an active war that you can still fight and a fixed scar you just have to manage.
Because that distinction changes everything.
It really does. So, to grasp how skin gets permanently scarred in the first place,
Yeah.
I feel like we have to look at the fire that burns it down.
Absolutely. You have to start with the active phase.
Right, and clinical pathology draws a massive, heavy line between simple skin irritation and true inflammation, right?
Right.
They're radically different biological events,
Totally different. I mean, irritation is just superficial wear and tear.
like using a harsh soap.
Exactly. You use a stripping soap, you lose some surface oils, the skin gets a little chafed and angry. But true inflammation, especially the kind we see in the early stages of lichen sclerosus, that's different.
It's an immune response,
It's a highly coordinated military operation executed by your own immune system.
which is terrifying when you look through the microscope at this early phase. Pathologists call it the lichenoid reaction pattern.
Yeah, and it looks like a literal invasion.
The cellular notes describe this dense, band-like infiltrate of immune cells, and they say it violently hugs the dermoepidermal junction.
Right, so that junction is the exact boundary separating your epidermis, which is the outer protective layer of skin you can actually touch, and the dermis.
The dermis being the thicker, nutrient-rich middle layer underneath, right?
Exactly. And this border, it isn't just a flat line. It has these wavy downward projections called reet ridges.
Okay, so it's not a straight line, it's wavy.
Yeah. Those waves give the skin its mechanical grip. They literally keep that top layer from just sliding off when you rub it.
Oh, wow. I never thought about that. So this immune army marches in, sets up a tightly packed camp right on that wavy border wall, and just actively attacks the neighboring cells.
The keratinocyte cells, yeah.
Yeah.
And they cause what pathologists call vacuolar change.
Which is a very clinical way of saying they're blowing holes in the local cells and destroying them.
Yeah, they are blowing them apart. And they don't do this quietly either. This dense band of lymphocytes, these specialized immune cells, they're constantly pumping out pro-inflammatory mediators.
Chemical messengers.
Right. These chemicals flood the local tissue to signal for increased blood flow. They dilate the capillaries and draw even more troops to the war zone.
It's like calling in reinforcements.
Exactly. And this localized chemical storm is what causes the intense pruritus.
The severe itching that patients experience. I've always wondered about the actual mechanics of an itch. Like,
Yeah.
is it just a physical sensation of the cells being destroyed?
No, it's actually the chemical messengers themselves. They physically bind to and irritate the highly sensitive nerve endings embedded right there in that dermoepidermal junction.
So the nerves are just panicking.
Basically, yeah. The nerve fires a frantic signal to the brain saying, something is attacking us, scratch it off.
So the itching is really a blaring, unavoidable alarm bell that your immune system is highly active.
Exactly. But there is a crucial silver lining during this early, itchy, agonizing phase.
Which is,
The architecture of the skin, those wavy ridges giving it grip, the hair follicles, the sweat glands, they are all still structurally intact.
okay, so the batter is raging, but the buildings haven't fallen down yet.
Precisely. This is the critical window where aggressive medical intervention can theoretically put the fire out.
And allow the skin's architecture to fully recover without leaving a trace.
Right. But, that window closes eventually.
Yeah. And when the fire isn't put out, the body basically panics, right? It tries to patch the damage in the most extreme way possible.
It transitions into late-stage lichen sclerosus, and this fundamentally alters the tissue.
So the pathology drastically shifts from active inflammation to what they call a sclerosing dermatitis.
Yeah. And to understand the danger here, we really have to contrast how a normal scar forms with what happens during sclerosis.
Okay, so a normal scar is basically a fibrous patch job.
Right. You get a deep cut, the body lays down new collagen bundles, usually parallel to the surface, just to close the hole.
And under a microscope, normal, healthy skin has this flexible woven look.
Yeah, a beautiful, dynamic basket weave pattern. It's very organized. But in late-stage lichen sclerosus, the pathology highlights the homogenization and sclerosis of dermal collagen.
Okay, let's translate homogenization into plain English.
It basically means all those distinct, flexible, woven individual fibers just blend together. They turn into a single, dense, featureless mass.
Like they melt together.
Sort of, yeah. The fibers become highly eosinophilic, so they stain this glaring pink under the microscope, and they become hyalinized.
Hyalinized. What does that mean for the tissue?
It means the tissue loses its cellular detail entirely. It takes on this glassy, transparent, almost crystalline appearance instead of looking like living, breathing tissue.
Wow. So essentially the body is pouring a thick, heavy layer of glassy concrete over a lush lawn.
Mechanically speaking, yeah, that is a perfect description of the resulting structure.
And on this lush lawn, you normally have adnexal structures, right? Hair follicles, sebaceous glands, sweat glands.
Right. But this hypertrophic, dense collagen concrete physically replaces the underlying fat and just squishes those delicate structures out of existence.
It suffocates them completely.
It really does. The sclerotic collagen expands, pushes those structures upward, and leaves absolutely no space between the glassy fibers for them to receive blood flow or survive. They are choked out.
Which alters the skin's surface so dramatically, it takes on an atrophic white cigarette paper appearance.
Yeah, it becomes thin, crinkled, and just completely devoid of its normal texture and elasticity.
But, here's the detail from the pathology notes that completely stopped me in my tracks.
Oh, about the inflammation?
Yes. The biopsy shows that the original band of lymphocytic inflammation, that invading army we talked about, it hasn't disappeared.
No, it hasn't.
It's been pushed completely below this massive layer of glassy sclerotic collagen.
The army is literally trapped deep underground beneath the concrete slab.
Wait, if they are trapped under a dense, suffocating layer of glassy concrete, shouldn't they just, run out of oxygen or nutrients and die off? Why is it a problem if they're buried?
You would think they would naturally die out, wouldn't you? But the dermis beneath that scar tissue still maintains a blood supply.
Oh, so they are still getting fed.
Exactly. The cells are surviving, and worse, they're still pumping out inflammatory signals.
That's awful.
Right. Because of the dense scar tissue above them, the body's normal mechanisms for clearing out the inflammation are just totally blocked. They become stuck in this localized loop of destruction.
And because those complex anatomical structures, the follicles, the reed ridges, have been replaced by this fibrous, glassy collagen, you can't just plant new flowers in solid concrete.
No, you really can't. Once that intricate architectural scaffolding is overwritten by sclerosis, it cannot be salvaged.
The tissue's blueprint is fundamentally changed.
Exactly. And that is why fixed scarring is considered an irreversible endpoint in dermatology.
But this creates a huge problem, doesn't it? If this concrete scar is opaque and the invading army is trapped underground, doctors are essentially blind.
Yes, that's the challenge, yes.
Like, you could look at a patient's skin, see a flat, white, crinkled surface, and assume the disease is totally burned out. How do they possibly know if the fire is still raging out of sight?
Well, relying purely on visual inspection is a massive clinical pitfall. A fully healed, inactive scar looks nearly identical to a scar that is harboring a raging underground immune response.
So what do? The literature points to two distinct tools doctors use to spot the difference.
Right.
One is a classic bedside technique, and the other is absolute cutting-edge technology. Let's start with the low-tech option, the Blanche test.
Okay, so dermatologists use the Blanche test to distinguish active vascular inflammation, which they call post-inflammatory erythema, from fixed pigment changes left behind by old damage.
Which is known as post-inflammatory hyperpigmentation.
Ex-
So if you take a clear glass slide and press it firmly against a red or discolored area on your skin, you're basically looking to see how the blood reacts.
Right. You press, hold, and release. If the area turns white or blanches under the physical pressure and then rapidly fills back up with red blood the second you let go, you are looking at active vascular inflammation.
Meaning your capillaries are dilated and actively rushing blood to an ongoing fight.
The fire is still burning.
But if you press the glass down and the dark mark doesn't change color at all,
That means the discoloration isn't from active blood flow, it's from melanin.
just fixed pigment.
Yeah, fixed pigment that dropped down into the deeper skin layers during a previous inflammatory phase. It's a static footprint of an old fire, not a current one.
I mean, that's a great trick for surface level redness.
Hmm.
But our lichen sclerosus patient has a thick, white, concrete-like scar on top.
Yeah, a glass slide isn't going to penetrate that opaque layer to show us the trapped army underneath.
So it fails completely in that scenario.
It really does. So to see through the concrete, dermatologists have to turn to high-frequency ultrasound, or HFUS.
Which is fascinating. We usually think of ultrasound for looking at babies, but this is high frequency, specifically tuned for penetrating the skin.
Right. And the research paper we reviewed on assessing connective tissue diseases explains that it measures echogenicity.
Meaning how sound waves bounce back off different types of tissues.
Exactly. Healthy, organized collagen reflects sound waves in a very uniform, predictable pattern. It looks bright and structured on the monitor.
But active inflammation drastically alters the physical state of the tissue.
Because inflammation brings a massive influx of fluid.
Viva, right. The entire war zone is flooded.
Flooded, you have blood serum leaking from dilated vessels, swarms of immune cells, all of it pooling locally in the dermis.
And sound waves travel differently through fluid than they do through solid collagen.
Right, sound waves zip straight through the fluid without bouncing back to the probe. So on the ultrasound screen, this creates dark, low echogenicity voids.
Oh, wow. So it just looks like a dark patch.
Yeah, and dermatologists look for a very specific anatomical marker called a SLE.
A subepidermal low echogenicity band.
Exactly. So as the doctor glides the ultrasound probe across the skin, moving from a healthy area toward the diseased area, this dark band starts to emerge on the screen, getting thicker and blacker.
And the darkest, thickest parts of the SLE correspond perfectly to where the massive inflammatory changes and fluid buildup are happening beneath the scar tissue.
You've got it.
That is, frankly, terrifying when you consider the implications. Like, the data from that ultrasound study proves that the very top outer layer of the skin, the epidermis, might measure absolutely identical in thickness between the healthy areas and the severely diseased areas.
Visually, there's no difference.
Right. You could have a seemingly calm, flat surface, indistinguishable from the skin next to it, but the ultrasound reveals a flooded, low-density war zone churning away just 1 millimeter down.
The surface provides a complete false sense of security. HFUS provides the definitive physical proof.
It tells the doctor whether that deeper band of inflammation in lichen sclerosus is actively churning out destruction and requires aggressive immunosuppressive drugs, or if it's purely a dense sclerotic scar with no active fire remaining.
Which is the most important distinction you can make.
Well, let's talk about why. We've mapped out the microscopic pathology, we've explored the ultrasound physics, now we have to bring this directly back to you, the listener.
Right. Why does this matter for your treatment?
Exactly. Why does it actually matter whether you have an active hidden fire or a fixed scar?
Because your entire management strategy hinges on this single distinction. The treatments for putting out a fire are completely useless for removing concrete.
Right. So if the clinical symptoms or the ultrasound reveal an active underground inflammation, the primary care dermatology guidelines are incredibly aggressive, aren't they?
Very. The goal is immediate intervention to halt further architectural loss.
You have to extinguish that immune response before it permanently destroys more adnexal structures.
Yes. This is particularly crucial in conditions like scarring alopecias, where hair follicles are under direct attack.
Because once they are gone, they are gone.
Exactly. Follicles that are already destroyed by sclerosis cannot be brought back, so the entire medical focus is on saving the ones that are still alive.
But if the concrete is already set and the ultrasound shows no dark fluid band,
Hmm.
just bright, hard sclerosis, treating that fixed scar with heavy anti-inflammatory drugs like strong topical steroids is completely futile.
It's worse than futile. You can't unhomogenize glassy collagen with a steroid cream.
Right.
And continuing to apply potent drugs to a burned out scar exposes the patient to severe side effects, like profound thinning of the surrounding healthy skin, or even systemic absorption for absolutely zero therapeutic benefit.
So misinterpreting the signs goes both ways. You don't want to waste drugs on a fixed scar, but you also can't afford to ignore an active underground fire just because the surface looks healed.
Because if that army is still down there firing off chemical weapons, they are causing ongoing cellular damage.
And some of the literature suggests chronic unchecked inflammation can even increase the risk of cellular mutations over decades, right?
Right. A prolonged, unmanaged immune response is deeply dangerous to the surrounding healthy tissue.
Okay, so if a patient has a fixed scar and creams won't work, the natural thought is, well, I'll just get a surgeon to cut it out.
That's what a lot of people assume.
But the clinical commissioning policies from the NHS in Cheshire and Merseyside paint a very sobering picture of surgical revision.
Yeah, because surgery on an inflammatory scar is incredibly risky.
Why is that?
Well, you are essentially creating another full-thickness injury with a scalpel, which is the exact physical trauma that triggered the body's immune system to overproduce collagen in the first place.
Oh, so you're just inviting the army back.
Basically, their policy states that surgery carries a very high risk of making the skull significantly worse, or triggering a massive recurrence of the disease right along the incision line.
In fact, they refuse to routinely commission surgical scar revision unless incredibly strict criteria are met.
They typically mandate a waiting period of at least 1 to 2 years after an injury, just to see if natural fading occurs.
And even then, they don't approve it simply to improve cosmetic appearance.
No, they only intervene if the scar is causing severe functional difficulties or debilitating pain that actively prevents you from performing daily tasks.
It has to be functionally impairing because the chance of a worse outcome is simply too high.
Right.
We shouldn't minimize this, by the way. Scars cause profound distress. The literature points out that conditions involving widespread scarring, like expensive morphea or localized scleroderma,
Which are autoimmune conditions where the body overproduces collagen in large, hardened patches across the skin.
exactly, those alter a person's body image and psychological well-being immensely.
Absolutely. Which reinforces why early detection of the active fire is paramount. If you are listening to this and dealing with a skin condition, you have to advocate for yourself using these physiological clues.
So if you are experiencing that deep, constant itch or unexplained localized warmth, or if you do a blanch test and see that rapid refilling of blood,
Your immune system is still actively fighting.
right,
Don't fall into the trap of endlessly cycling through over-the-counter moisturizers, hoping it will just gently fade away. Seek a professional assessment.
have a dermatologist evaluate the specific patterns.
Perhaps utilize HFUS to look beneath the surface and stop the concrete from being poured while you still can.
Wow. Let's pull all these threads together.
Okay.
We've journeyed from the aggressive, border-hugging immune camps of early lichenoid inflammation, where chemical messengers trigger a blaring alarm of itch.
And we watched that active war zone collapse into the irreversible glassy concrete of late-stage sclerosis, suffocating the delicate structures of the skin.
Yeah. By using lichen sclerosus as our map, we uncovered the dangerous deception of the skin's surface, where a flooded war zone can hide beneath a perfectly calm exterior.
And we explored how high-frequency sound waves can finally pierce that veil to reveal the biological truth.
It is a phenomenal microscopic saga playing out in millions of people right now.
It really is.
But before we wrap up, I want to leave you with a provocative thought drawn from the deeper pathology we reviewed. We know that fibroblasts and collagen in the human body are in a constant, lifelong state of remodeling, right?
Yes, your skin is never truly a static, finished product.
It's a living, breathing, continuously updating organ.
Exactly.
So if the tissue is constantly remodeling itself, Could future medical breakthroughs learn to hack that system?
Oh, that's an interesting question.
Right. Could we develop a biological key to chemically dissolve that glassy concrete slab of a fixed scar and reverse engineer the collagen back into a healthy, flexible basket weave pattern?
It completely challenges our entire concept of permanence. Is a permanent scar actually an unchangeable biological reality, or is it just a temporary limitation of our current science?
It's definitely something for you to ponder the next time you look at a scar on your own body and realize it's not just a mark. It is a monument to a microscopic battle that you survived. Keep looking beneath the surface.